Greetings of the day, folks. Today we are going to discuss about hemolytic uremic syndrome. So, hemolytic uremic syndrome is a multi-system disorder resulting in AKI, hematologically involves subthrombocytopenia, and also RBC cells are involved due to microangiopathic hemolytic anemia. So, hemolytic uremic syndrome is one of the most common causes of AKI in children and mostly seen in less than 10 years old. It is classified as typical when it is associated diarrhea or atypical. In children, sugar toxin producing E. coli causes 90% of hemolytic uremic syndrome, presenting with a prodrome of a bloody diarrhea. And in 10 to 15% of patients will be having sugar toxin producing E. coli, which may develop hemolytic uremic syndrome. Other causes of hemolytic uremic syndrome are strep pneumonia, infection, genetic disorders, oral contraceptives, pregnancy, and malignancy. Despite widespread immunization or strep pneumoniae, the incidence of hemolytic uremic syndrome associated with invasive disease has not decreased, and non-vaccine strains have replaced the vaccine strains. And mortality and severe renal involvement are higher in strep pneumonia associated hemolytic uremic syndrome than typical sugar toxin associated uh, E. coli associated disease. So the pathophysiology is the epidemic hemolytic uremic syndrome is usually caused by infection with E. coli O157 uh, hash, semicolon H7, an organism associated with ingestion of undercooked meat and unpasteurized milk and contaminated fruits and vegetables. E. coli O157H7 produces a sugar toxin which is absorbed from the intestine into the circulation. It causes endothelial damage and leading to microangiopathic intravascular thrombosis, which leads to RBC hemolysis and also thrombocytopenia due to platelet consumption. And because the nephrons are having afferent small arterioles, there will be decreased glomerular perfusion because of microangiopathy. The microthrombi are deposited in the kidney parenchyma and it causes hypertension, oliguria, and anuria. Renal involvement ranges from mild renal insufficiency to AK requiring dialysis. So that's how severe the HUS is. In typical cases associated with strep pneumonia, like 5% of cases, the pathogenesis is also initiated by pneumococcal enzyme neuraminidase. This enzyme cleaves N-acetyluraminic acid from surface of RBCs and endothelial cells, uncovering the T antigen on the surface of endothelial cells. This in turn leads to an immune response initiating cascade leading to HUS. Okay, so because of this, there will be the microangiopathy and leading to AKI and HUS. So the majority of the HUS is associated with the E. coli enteritis. The clinical features in enteritis. So enteritis, the patient will be having GI related symptoms, that is nausea, vomiting, and bloody diarrhea with or without fever. Okay. So with or without fever. Within a week of resolution of GI symptoms, patient will develop pallor, edema, and oliguria or encephalopathy or seizure. So strep pneumonia-associated hemolytic uremic syndrome can accompany severe invasive disease typical in the setting of pneumonia, sepsis, or meningitis. Other complications include hypertension, heart failure and resuscitation, diabetic mellitus, acidosis, and colitis. So we must ask about the dietary and travel history, which may identify the potential cause of public health officials to aid of infection to aid in public health officials and assess epidemic outbreaks risks. So in coming to these are the features. So GI related, after 1 week, the patient will be having the kidney related edema, pallor, oliguria, SOB, and seizures or encephalopathy. And strep pneumonia will be having some pneumonia or sepsis or meningitis related complication later on leading to this. So coming to the lab investigations, normally we'll send for CBC, complete blood picture, and peripheral smear. And so this gives us a there will be microangiopathic. Because of this, there will be hemolytic uremic syndrome, right? So the hemoglobin level falls between 5 and 9, and the smear demonstrates cystocytes, helmet cells, and Burr cells, which are consistent with the microangiopathy. The platelets count will be decreased because of consumption of platelets. The WBC count may be elevated, which will be causing poor prognosis, which is suggestive of poor prognosis if obtained Coombs test is negative. And we must check electrolytes and the renal and hepatic function. Hyponatremia and hyperkalemia develop as a result of metabolic acidosis from renal failure. Hyperbilirubinemia results from acute hemolysis. Okay, so as a result of hyperkalemia, so there will renal failure, there will be metabolic acidosis, and due to acute hemolysis there will be hyperbilirubinemia, so patient might develop jaundice. So we must send a stool specimen for culture and to test for sugar toxin. Okay, so urinalysis demonstrate gross or microscopic hematuria with granular and hyaline cas and variable proteinuria and leukocyturia. So in the ED management is supportive, although some studies early aggressive volume expansion may improve outcomes in typical correct life-threatening. We must correct the underlying electrolytes disturbances and treat hypovolemia with IV fluid bolus, that is 10 to 20 milliliters per kg normal saline. And antibiotics are contraindicated in pediatric diarrheal illness and may increase risk of hemolytic uremic syndrome. Antiperistaltic agents increase the risk for systemic complication, and it is more mainly associated with E. coli infection and are also contraindicated. The blood transfusion may be needed for severe anemia patients, and platelet transfusion is not recommended because it can worsen the thrombotic process because there will be platelet consumption. And treatment with eculizumab or plasma exchange may be helpful. All patients with hemolytic uremic syndrome require hospitalization. Patients with neurologic symptoms and oliguric renal failure should be admitted to ICU. Renal replacement therapy is required approximately half of patients of acute hemolytic uremic syndrome. Most children survive the acute phase of illness and most regain normal renal function. This completes the RHUS presentation. Thank you.